Well, let's talk about our case. Remember Winona, and she comes to us now, has been treated for atopic dermatitis, but is not responding. And so what we decide to do, based on everything we've discussed, is to go to a stronger topical corticosteroid, and she seems to do much better. She's happy, her parents are happy, and her skin looks a lot better. The question is, Amy, what if Winona doesn't respond to her stepped-up therapy? What do we do in that scenario?
Yeah.
And what options do we have available to us?
And that's particularly common when you're talking about someone with moderate to severe disease. And I think the first thing that we need to do is obviously make sure we're not missing something. Is there some staphylococcal infection that needs a systemic antibiotic? And of course, we got to get in that maintenance therapy with the dilute bleach baths. Is there a possibility that she's having a contact allergic response to something that's being applied, or something that she just may be in contact with at home that's mimicking the atopic dermatitis and needs to be identified? We know with contact allergies that we may get some mileage out of the topical steroids, but that can be very difficult. And what we really need to do is identify the triggers and avoid them. And then, of course, other possible diagnoses. But if indeed the problem is just that her atopic dermatitis is severe enough that we need to ramp up even further, then we need to think about systemic options. We always think about phototherapy first. Narrowband ultraviolet B light is most commonly used because of its low-risk profile. It's relatively effective. It's pretty easily available in doctors' offices, and we can even try to get home units. And there's been a fair amount of experience with it. But for many people, it's difficult with respect to adherence. We know that it may be hard, particularly for children who have tremendous amount of after-school activities, parents often working, to get into the doctor's office for this type of treatment. It's not usually what we choose as our first-line therapy when somebody's very severely involved, because it can be poorly tolerated when the skin is very erythematous. There are some potential adverse events we need to think about, like burning and long-term actinic damage, although the narrowband ultraviolet B is pretty safe. And finally, I did mention home phototherapy for patients who just can't get to the doctor's office, but that's expensive and hard to get these days from insurance companies. So we usually have to think then about a systemic immunosuppressive agent, and that's all we have to work with. And because of our concerns about these agents, we have a pretty high bar before we get to those, although they can be highly effective and dramatically change the quality of life for these more severely affected individuals. One of the problems we have is that many of these agents have been around for a long time, and there aren't really good comparative trial data available to know the relative efficacy and safety of these various options. Now, in the United States, most commonly used are cyclosporin, methotrexate, mycophenolate in that order. In Europe, azathioprine has also been used. In general, we worry about systemic corticosteroids. I don't use them at all in children. They often lead to rebound when stopped, and we've seen this repeatedly, for example, in our kids with atopic dermatitis who get treated with a burst of steroid, and their eczema starts to get better, and then boom, they stop the medication, and it's back with vengeance. They're used a little bit more in adults, and they certainly can be a short bridge for severe exacerbations, but you have to have a plan of what to do more long-term, or else you're on this roller coaster of use of systemic steroids, which are very dangerous in children, but have many risks as well in adults.
In my experience with adults treating with systemic steroids for acute flares for any dermatological condition is that if you choose to do that, you better be sure you have them on topical corticosteroids as you taper off of the oral systemic steroids to prevent the disease from flaring up again.
Absolutely. Yeah. And in the most severe cases, of course, topical steroids aren't going to hold them, but as a great bridge for those who don't need the systemic agents, that works very well. Now, I want to remind that we don't use antibiotics except for infection. They really have no role, just used empirically unless there is that evidence. And as we mentioned before, the antihistamines are largely used for their sedating properties.
Well, there have been other interventions that have been used over the years. Even when I was in training, we would use things such as primrose oil or omega-3, things of that nature. These are really not supported in treatment guidelines, nor do we use these much anymore, because there really isn't good evidence that they have any efficacy for controlling chronic atopic dermatitis. And the same could be said for probiotics, which are very much in vogue today. There's limited data, though, suggesting some benefit in some studies, but I think it's still controversial. There's no great consensus on whether probiotics are useful in treating most of our patients.
So let's go back to Winona, who was not responding adequately to appropriate topical steroids and really didn't have any other reason. We found no infection. We didn't find any other possible exacerbant or alternative diagnosis. She wasn't going to be able to comply with phototherapy, so we advanced her to a systemic immunosuppressive agent. In this case, a 3-month course of cyclosporin brought her into good control. But then there was maintenance, and we don't like to use cyclosporin for long periods of time. There's evidence that if you continue beyond a year, you really can have evidence of renal effects. So we like to transition. I generally transition after about 3 months. And in this case, we chose to transition her to methotrexate with a little bit of an overlap between the cyclosporin and methotrexate, because methotrexate can take a few months to truly be effective. And she's done very well with that. After her initial improvement with the cyclosporin, she was able to maintain that with methotrexate. Her labs have been fine, and she's continuing in good control.
I like to use cyclosporin in these very difficult cases, but I prefer using it, as you mentioned, just as short a period of time as necessary, months at a time, because almost always I'll see side effects in our patients.